Thank you so much for coming today. And also we have a large number of people attending by Zoom. So thank you so much for tuning in. It's a nice option that we can do both. It feels good to be together, but we know in this age that we can do both. We can be together and we can still Zoom when we need to. We have people joining from all over the world. Thank you so much for getting up late in the night, or if you're up early in the morning, traveling, getting on a plane, driving in, taking the train. We're really happy to be here. And thank you so much, more than anything, for being strong allies for global mental health. Um, the impact of our program is significant, and you'll hear about that today. We have a tightly packed program, but one of the things that we really pride ourselves in being able to do and to contribute into the world is the ability to zoom in. Will help these grant programs to go forward to the next step. And then we can zoom out, take that information, and go to other places in the world, including the US, of course, because we are part of the globe. And you'll hear more about it today, but we're very proud of the 12 research projects that have gone forth before this, and we have 4 more that will be launched this year. So you'll hear more about that. Thank you again. I'm going to introduce you to Tahilia Rebello, who is the co-chair of the Council Grant Review Committee.
Hello, good afternoon, everybody. It's lovely to see you all and to be here with all of you after a long hiatus, way too long. Thanks, Jerry, for the introduction. There you are. As Jerry mentioned, I'm Tahilia Rebello, and I serve as a faculty member on the Columbia Global Mental Health Programs and also as co-chair along with my colleague, Dr. Jeremy Kane, who is unable to be here in person with us today. We have been co-chairs for the Council Grant Program since its inception in 2019. And essentially what that means is that we oversee the process of developing the call for applications, work with our steering committee, and other faculty and program staff at Columbia and elsewhere to seek out potential candidates for the grant and to really lead the grant review process so that we can identify the top projects that receive support and grant funding via this council mechanism that all of you have contributed to. So as a council member, your support has really been invaluable for setting up the grant program, which, as you may know, is the council's keystone initiative. And we really thank you for your support and presence here today, both in person and online. This important funding mechanism really helps support new ideas in global mental health research with these one-year pilot grants. It serves as a catalyst for generating and supporting novel work in global mental health and is really a unique program that allows for more innovative and really important projects to be supported. Having actually been a recipient of a similar grant program in the past as an early investigator, I can firsthand appreciate the value of such support early on in the process of my development. And so in the brief time I have with you today, it's my pleasure to provide you with some updates on the global mental health projects that you as a council have supported in the past. So in the first year of the program in 2019, we received 22 proposals from around the world with some connection to faculty at Columbia and projects being implemented by faculty at Columbia. And these proposals were from over 15 countries across the entire world. Since then, we have, as Jerry mentioned, been able to support 12 mental health projects, 4 of which we will hear about in greater detail as part of this afternoon's agenda. As intended, these proposals which we received were diverse, unique, and really highly relevant to global mental health and captured in many ways the broad priority areas in global mental health. So for some brief concrete examples, in 2019, you as a council funded a project that was led by Drs. Laura Cardisco-Sai and Katie Carlson. Their project was done in the Philippines with survivors of human trafficking, a group that you can imagine has experienced a lot of trauma that can have a really tremendous impact on their mental health. Many of these individuals experience mental distress that can lead them to sometimes attempts at taking their own life. In this funding year, in that funding year, this project team was able to really create a culturally appropriate program for helping screen for suicide and self-harming behaviors and provide care for survivors of human trafficking. They were also able to train many local community members on how to do this suicide prevention work and already started getting valuable mental health care to survivors and collecting really important data around whether the program was working or not, what could be strengthened, et cetera. And they found just in that 1 year funding period that through their program, which was funded by the council, they were already able to see a decline in suicide risk by about 95% by the metrics that they collected, which is really tremendous work. Your support also went towards funding Dr. Sion Faru, who is here, and I'm sure would love to elaborate on the work that she continues to do in partnership with Dr. Claire Green, who is also here. So their work briefly was done in Ethiopia and focused on better understanding the mental health needs and the types of mental health resources available to a particularly vulnerable group of people within Ethiopia. So Sion and Claire's project, and then this vulnerable group was refugees and internally displaced people within the country. So Sion and Claire's project was really important because we know that in terms of mental health, this is a really vulnerable population who've experienced extreme distress and trauma and may be in need of mental health services. So it was really important for us to be able to map out those services and be able to identify gaps in care and then as the first step to meeting them. So over the funding year, their team was able to have many essential interviews and build partnerships with many of the people who either provide care for refugees, such as clinicians, or help organize and fund care, like government officials as an example, to really get at this question of what resources exist. And through their work during the council grant funding period, they were able to see what services were available and really important, what services were not available. So they, as I mentioned, can work towards filling in these gaps to get refugees and internally displaced people the care that they may need. Again, really great work, and they are around to further elaborate. The other projects funded that year went to Drs. Oreja Grimm and Dr. Roberto Luis Fernandez, who worked with a really important population within the United States, so unaccompanied Latin American migrant youth arriving in the United States, to try and understand their coping strategies and where and how they seek community resources. You were also able to support Dr. Franco Mascayano, who worked on establishing and testing kind of the early phases of that project, an early psychosis identification program based in Chile. In the following year, your support went towards funding 4 additional highly relevant, high quality programs, which included Dr. Ali Gusto's program on essentially setting up a community and family-based intervention that helped to address the use or misuse of alcohol in new fathers in Kenya. Dr. Lola Kola, who is based in Nigeria, who worked on a digital video intervention for adolescent mothers experiencing perinatal depression. Dr. Maria Elena Medina Mora, who is a senior investigator, very senior in Mexico, whose work focused on developing a way to essentially concretely estimate the population of Central American migrants in Mexico and to assess their mental health needs. And finally, that year, we were, as a council and as a program, able to support the work of Dr. Muller and Matz, who investigated the impact of the COVID-19 pandemic and on behaviors related to social distancing, and then its subsequent impact on mental health. Again, as a first step of identifying gaps and services that were required. So as you can appreciate, especially for the 2020 cycle, the 4 recipients that year really started their projects almost at the start of the COVID-19 pandemic and had to kind of code shift in some ways and make necessary modifications. But they really, despite these challenges, were able to make these necessary modifications and made some excellent progress. And in some cases, they were even able to capture or respond to the impact of the pandemic on the mental health needs of the people that they were working with. So to wrap up, over the funding period and beyond, grant recipients were really able to implement programs, as we've heard, collect really important data on whether those programs were working, what are the gaps, begin advocating for change, politically, for example, publish papers to be able to share their work more broadly with the scientific and research and public health community, and to ensure the sustainability of their really important work by applying for larger grants. And in most cases, and as intended, funding from the Council Grants Program was really an invaluable component to them taking these next important steps and growing and expanding their programs and research. So I hope you can appreciate that your contributions were able to fund a really fantastic body of work. And again, we thank you all for your support. And I'm really excited to hear in more concrete detail about the 4 projects that we have funded last year. Thank you.
Hey, hi, everybody. It's not good morning, it's good afternoon. It's such a pleasure to be here with all of you, also to be here in person with the few of us that were able to make it. I've been involved with this since the beginning with Kathy and the whole group that we're doing, and it is such a pleasure to be able to help us fund the next generation. I'm a professor of clinical psychiatry at Columbia. I do global mental health research, both domestic and abroad. And I have the pleasure to have fellowships in the US, Africa, and Asia to help the young minds that you give a little bit of, the beginning of their stage careers to get their careers really happening. And I'm going to add to what Hilly just said, that there's already grants that have gotten from NIH from these projects, which is very hard to get. The one in Chile is right now a very large study. The Annika that we'll present today already got where is Annika? I don't see you. Oh, there you are. So we really, and let me tell you, it's not easy to get grants. It's competitive that you have no idea. We suffer how competitive it is, but we've already seen the products of what we're doing. So I have the pleasure to introduce these young people, these young minds, this young amazing group. And I'm not going to tell you too much about them. I'm just going to tell you, I'm going to go one by one. First, Annika Sweetland, who began as a fellow in my fellowship and now is a colleague that I respect and play with, which is fantastic. And she has done something so novel. She's looking at how do you look at many diseases at the same time. In research, we do one at a time. She's doing multimorbidity. So I'm going to let her talk about that, and you have 4 minutes. Please join me. And I have a time.
Hello, good afternoon. I'm very pleased to be here. This project that I'm going to describe is in partnership with Dr. Fran Cornos, who I think is here virtually, wasn't able to be here in person. So my project is looking at multimorbidities in Mozambique. And multimorbidities is really just like a complicated way of saying multiple chronic diseases at the same time. And in the US and in many, well, it's common everywhere, but in the US, it tends to be something that's associated with age. As people get older, and particularly when people live longer, they get more and more illnesses. And it tends to be an additive process. And this is not necessarily the case in many low and middle income countries where infectious diseases are quite common. So it's complicated. Health systems, as Milton mentioned, are not designed for multiple conditions at the same time. And so that's a challenge, right? So you can imagine, for example, a provider comes in to see their cancer patient and they say, oh, the patient also has diabetes and HIV and depression, and it can be overwhelming for a provider to figure out sort of where to start. And a lot of providers in that situation sort of either just pick one disorder, okay, we're just going to talk about cancer today, or they will focus on survival. How do I keep my patient alive? How do I get them to take their medications? And then you can think about on the flip side for the patient, it's also extremely overwhelming to have multiple conditions, and it's confusing. Oftentimes I get conflicting messages from different providers. And also they might have very different priorities, particularly in settings of poverty. They might be most concerned with getting food on the table, and HIV is, 10 things down the list. So it's that lack of alignment and communication that often contributes to poor health outcomes. So for this project, I'm looking at the intersection of TB, tuberculosis, HIV, mental disorders, and substance use disorders, which are all very, it's the more I've worked with TB for a very long time, TB and depression, and I've found that the complex cases is much more the norm than the exception. And understanding, so 50% of people with TB have depression, and many of those people have substance use problems and self-medicating, and 60% of people in Mozambique who have TB also have HIV. And so really this complexity, if we don't address that in the right way, we're not going to have very good quality clinical outcomes. So the purpose of the study is really, it's a qualitative study. I'm going to talk to providers and understand from their perspective how they manage multimorbidities, how the complexity, talk to patients, try to get their perspectives, and try to find a way to bridge this communication gap so that we can improve care.
We have room for one question. So burning question, only one, because we are on a tight schedule. Anybody? I have. What are your next steps?
Oh my gosh, getting that off the ground. But this grant mechanism is unique to the extent that I would love to get NIH funding to do multimorbidities research, but as a young investigator, there's no way. From a grantsmanship perspective, they're never going to fund that unless I can really come in with something very, very concrete. So that's where this particular grant fits in. So in South Africa, I'm doing a study with TB and depression, and I wanted to do TB and depression and HIV and alcohol. And they said, when I took those out is when I got funded. But really my aspiration is to address all of these complexities at a large scale. And so this is a really important seed funding towards that goal.
So then I have the pleasure to introduce Christina Merambot, who I heard is a phenomenal PhD student, right? Her mentor is a little biased, but she says that. And her novelty is that they're looking at substance use in Armenia with youth that nobody has ever looked into. So could you please join me here and present your work?
Hi, everybody. I wanted to actually give you just a little bit of background as me. I would say very new researcher. My name's Christina Merambot. I'm a second year PhD student in the Department of Epidemiology at the Mailman School of Public Health here at Columbia. And I'm so excited and honored to be a recipient of this grant. My project is titled Post-War Mid-Pandemic, a mixed method study of alcohol consumption patterns and the alcohol use environment in young adults in Yerevan, Armenia. And so a bit of background about me is that I'm the daughter of two refugees, an Iranian father and a Lebanese Armenian mother. And so having grown up in a very multi-generational environment where cultural learning and knowledge was at the forefront of upbringing, I began my journey into public health and specifically epidemiology, maintaining sight on my various homes globally. So my great-grandparents were driven out of their historic homelands during the 1915 Armenian genocide, which has caused me to be very connected to my Armenian identity and ultimately lead me to study health in Armenia, a country of 3 million people nested in the Caucasus. So during my time at Columbia, one of my primary mentors introduced me to the world of alcohol epidemiology and spatial epidemiology. Alcohol consumption contributes up to 3 million deaths each year globally. And for ages 15 to 49, which is why I'm studying young adults, alcohol use is the leading risk factor for premature mortality and morbidity. So with spatial epidemiology, we know that space, place, and environment and the neighborhoods that surround people matter for mental health. So as I gained these skills here at Columbia, I decided to apply for this grant to study these topics in Armenia. And during 2020, Armenia, devastated by COVID, as most countries were in 2020, what made studying alcohol use so pertinent was at the same time as COVID was rampant, a war broke out and survival, trauma, and collective grief took over the nation. So with thousands of deaths and territorial losses, we know as researchers that traumatic events increase the risk of negative health outcomes, often co-occurring with substance use and unhealthy alcohol use. And these have significant implications for vulnerable populations. So populations experiencing collective adverse life events like a war and a simultaneous pandemic will face unique challenges in terms of mental health problems and disorders. So that's why this project looks to understand the alcohol use context in Armenia on a neighborhood level through focus groups with young adults and examine the potential for interventions with healthcare providers. The Republic of Armenia is a country that's young and has been independent for only about 30 years. So researching alcohol use, consumption, and norms in this context, especially in young adults with generations ahead of them, allows us to fill the gaps in the research world and provide clarity around recommendations of building programs related to unhealthy alcohol use and mental health. I'm incredibly grateful to be working with phenomenal researchers on this project, Dr. Jeremy Kane and Dr. Christopher Morrison of the Department of Epidemiology, and Dr. Kim Hekimian with the Institute of Nutrition. Yeah, that's Dr. Kim Hekimian. And of course, I'm just grateful for this council for giving me this opportunity early in my career to study the subject that's necessary and carries implications not only for Armenia, but countries like it that experience compounding events with implications for substance use and mental health. Thank you.
One burning question, and I hope that I don't have to be the only one asking the burning questions. Can you elaborate what you mean by geospatial epidemiology?
Yeah, so I guess quickly, I look at the impact of neighborhood characteristics on for this project, like mental health outcomes. So the first aim of this project was to go around and survey neighborhoods, neighborhood conditions, including graffiti and litter, and look at where people place alcohol outlets like liquor stores or alcohol advertising and who it targets, what neighborhoods it targets, and how that impacts health, because there's lots of links between neighborhoods and health in the future.
And just to add, why is this so important? Because then you know where to put resources, which is incredible. Yeah. Thank you so much.
Of course, thank you.
So we're so global that the next two people are going to be presenting from far away. First, we're going to have videos of them. Obviously, for one, we may be able to ask the question if the Zoom works. The other one is on the field right now doing the work that we're supposed to be doing, that they were paid to do, that got money to do. So first, let's talk Rogerio Mulumba, who is actually a PhD student in Mozambique. He's a psychiatrist and he's part of the University of Lurio. He is bringing the work of recovery-oriented psychosocial support for people with psychosis. And let me tell you quickly, in Mozambique, 30 million people, 20 psychiatrists. So when we're talking about doing this work, it's incredible. So shall we please run the video?
My name is Rogerio João Mulumba. I am a psychiatrist at the Luncheon Psychiatric Hospital in Mozambique. And I work in outpatient and inpatient service. And I'm also a PhD student at the Nami University. My research project consists in the socio-cultural adaptation of a psychosocial intervention called the social skill training for people with schizophrenia, and a feasibility study of its clinical use by primary care providers and the community health workers in the rehabilitation of people with schizophrenia. During my clinical activity as a psychiatrist, I had the opportunity to follow up two sisters with schizophrenia who lost their family support and were abandoned alone in a house. Even with the financial support of the family, but because of the abandonment, they started treating the disease. One of the persons developed a severe depression, and the another started to live on the streets. After many fruitless contacts with the family, we began to make home visits and doing some psychosocial intervention, which had a positive result as evidenced by the assumption of medication and the assumption of participation in the consultation, which means that they became independent and autonomous to deal with the disorders. Fortunately, for this case, it was not difficult for the clinical team to act because the two-sister residence was 2 kilometers from the hospital. But it is not possible to replicate this behavior for patients living in the remote districts and other provinces due to the lack of human resource and financial resource. In Mozambique, schizophrenia is the second reason for seeking for psychiatric consultation and the first reason for admission to psychiatric inpatient service. In Mozambique, the treatment of schizophrenia follows the medical model of symptom control with little psychosocial intervention to improve the patient's social function and promote recovery. Experience of the PRIDE project developed in Mozambique by Dr. Milton Weinberg and the Mozambique Ministry of Health demonstrate that it's possible to train primary care providers and community health workers to do psychotherapy to treat common mental illness such as depression, anxiety, PTSD, and panic disorder. So the lack of human resource in the area of mental health, the poor adherence and the abandonment of the treatment, the lack of family support, and inspired by the PRIDE project, we believe that the training of primary care providers and community health workers in psychosocial intervention for schizophrenia can help the patient and their family to better understand the disease without having to travel far from their area of residence, which can improve the treatment adherence, family support, and relapse prevention, using the existing human resource in that area, that health area. So this is a pilot start, a small start. The data that we will gather in the study, we won't be able to extrapolate to all the country because our sample is not so representative. But we are wondering that in the future we can do the same study in the large scale. So thank you for your attention.
Do we have Rogerio on Zoom or no? To see if we ask him one question. Or we don't have him.
Yes, I'm here. Hello.
Now we can upload. So
Hi.
any question for him? Because again, you have to think of questions, cannot be just me. So thank you so much for joining us from far away. It's 6 hours later there. The quick question that I have for you is, can you tell us a little bit about how the community council works in Mozambique, but very short? How does it work that the community is so engaged in everything that happens in health and mental health? Se você prefere falar em português, pode.
Ok. Preferia, sim, falar em português.
Uhum.
Portanto, os agentes comunitários de saúde em Moçambique são um ponto de ligação, portanto, entre os hospitais e as comunidades. E muitas vezes eles estão envolvidos mais em doenças infecciosas, né? Infecciosa, mas pouco se faz em relação àquilo que é, portanto, as doenças crônicas. Portanto, a ideia, portanto, do projeto portanto, colocar mais alguma atividade, portanto, dentro destes agentes comunitários de saúde, em vez só de fazerem trabalho relacionado somente com as doenças infecciosas, mas também que fizessem mais alguma coisa em relação, portanto, às doenças crônicas. Mas é um parceiro bastante importante, uma vez que nosso sistema de saúde baseia-se, portanto, nos serviços de saúde primária. Obrigado.
Obrigado a você. So why I asked the question is there's something called reciprocal learning, which is how do we bring things that we learn abroad in our global mental health work to the US? So these councils that he's talking about are really how the community helps the health system to figure out how to help the community. Up until now, they've only done it for infectious diseases. His work is introducing how mental health will be the community work to make sure that the health system responds to that. And why is this reciprocal learning? Because in the US, we don't have that. We may have amazing ways and infrastructures to do not enough work. However, one of the work, I am bringing that work to the US in a new mental wellness equity center that we're creating at Columbia to precisely see how the community, that was Portuguese in the middle, how the community can get involved in making sure that mental health is part of what we're doing in here. Thank you so much, Rosario.
Thank you. Thank you.
And last but not least, Jennifer Moots is on the field, so we're not going to be able to ask her any questions. Her innovation is that she is using digital work to try to find out how to do work with these internally displaced people also in Mozambique. And I think that we have a video where she can better explain her work.
Hi, everyone. I'm Jen Moots. I'm a psychologist and assistant professor in psychiatry, and I am joining you today via video and not in person. I'm sorry for that, but it is for a good reason, because I expect to be traveling to Mozambique at the time of this council, the first time since the onset of COVID. So very, very excited about that. Thank you for the opportunity to provide a quick update about our project with displaced people in Mozambique. And I want to start by thanking Dr. Mike Wessels, who is an expert in community partnered research, an important component of this project and has agreed to mentor this project, and Dr. Milton Weinberg, who is the principal investigator of the PRIDE study, and a study in collaboration with the Mozambique Ministry of Health, scaling up comprehensive mental health and substance use care across Nampula province and eventually the country. This project with displaced people leverages that prior work. I also want to say that the local principal investigator of this study, Dr. Antonio Solomon, who's head psychiatrist of Nampula province, had hoped to join me for this presentation, but he is in the field right now working to train community health workers to deliver a substance use intervention in their community setting. So he's very remote, and we tried to connect a couple of times this week via WhatsApp, and the connection was terrible. So we realized that we would not be able to connect via Zoom to do this video together. So sorry about that. So I just wanted to start by sharing the impetus and the reason why we applied for this funding. Tony, the head psychiatrist and partner on this project, was in the field training primary care providers to deliver mental health interventions. And he was approached by a health professional at that time, just raising or bringing his attention to all of the displaced people and asking if there was any way that we could help respond to the mental health needs of people who are relocating from Cabo Delgado, which is a province directly north of Nampula, because of a religious insurgency that has been ongoing since 2017, but has recently escalated fairly significantly. So the numbers now are estimated to be, hundreds of thousands of people have relocated, several of whom are coming to Nampula province, and many are relocating to Nampula city, where we have a strong team in place. So the premise of this project is to really just understand what the mental health needs might be for displaced people, especially those who are displaced to cities like Nampula city, because they have less visibility. They're not in a camp setting. They're often sort of dispersed throughout the city, many of whom stay with family members who can have 30 to 40 people in a household. So this year we've spent a lot of time forging those relationships in the community. Our team has been going to different neighborhoods, just asking, to meet with people who have been displaced, to understand, what they might want in terms of a project or mental health programming, if there are any natural leaders in the community who might want to work on our team with us, or what people recommend. So that way this summer we can go back and do more structured focus groups with displaced people to understand mental health needs better, and what they recommend from their perspective could be helpful for adaptation of mental health programming that we have in place through the Pride Project, and how we can adapt it to just be more relevant for displaced people and respond to their particular needs. So after we do the focus groups, we're going to have a work group with policymakers and community members, displaced people, mental health professionals, professionals who respond specifically to health and mental health, any psychosocial needs of displaced people. And we're going to come up with an implementation protocol and some strategies that can be tested and delivered in future projects. So I thank you very much for this funding. It has been essential and critical for the establishment of relationships, to make sure that we're getting community input, to ensure that this future programming and the strategies that we come up with and that the interventions are adapted in such a way that it's relevant for the community that we hope to serve. So thank you very much, and looking forward to hearing about the other presentations. Thank you.
So I'm going to save you. I'm not going to ask a question because she's not available. So what I want to close with is, you can be very proud. You do a lot, and you do the future. It's innovation, and it's what's going to be moving science in the next few years. So congratulations to you for being part of that. Now, please join me in welcoming Deanna Keenan, a longtime member of the council, who will to the stage to introduce the discussion on mental health in the context of emergencies. Thank you so much.
Hi, I'm Deanna Keenan, and I've been a member of this council since its inception. Additionally, I'm on the board of the National Alliance of Mental Illness of New York City, or Nami, New York City, where I also volunteer one day every week on the Nami helpline. I'm incredibly proud of the work that Nami does as a community-based, diverse organization that provides services free of charge and easy to access for everyone who needs them. Nami provides education and support for both individuals with a mental illness and for families and friends who care for those individuals, with classes like our 8-week family to family course, and support groups like Living with Bipolar or Black Lives Matter. As a member of this council's executive team, I suggested that we have the executive director of NAMI New York City be one of our discussion speakers today, which is why I'm up here doing these introductions. Before I introduce our guest speakers, just a quick word about NAMI New York City fundraiser. In a few weeks, on Sunday, May the 22nd, our annual Walk Street Festival will be at South Street Seaport this year. If you are in the city that weekend, we would love to have you join us for the festivities. I will leave flyers or cards or something on the back table for your information. Also, if you'd like to donate, I will make it easy. You can come see me. I can text you a little donation thing and you can donate easily. Okay, today I am honored to welcome and introduce our guest speakers who will engage in a discussion around mental health and the context of emergencies. Matt Kudish is the executive director of NAMI New York City. NAMI New York City is the largest NAMI affiliate in the country. As I mentioned before, NAMI helps families and individuals affected by mental illness build better lives through education, support, and advocacy at a city, state, and national levels. Under Matt's leadership, NAMI New York City has doubled its budget, staff, and impact, touching the lives of more than 30,000 individuals each year through its free programs and services. Matt has been named to New York City State's Healthcare Power list of New Yorkers who save lives for the last 4 consecutive years. Matt is respected in the industry to voice issues surrounding mental health, mental illness, caregiving, peer-based support, and accessibility. Matt received his master's in social work from Columbia University and his master's in public administration from NYU. He has also taught Columbia University School at the Columbia University School of Social Work and guest lectured at NYU's Silver School of Social Work. We are also honored to have Dr. Mark van Omeren. I haven't met you yet. Oh, okay. Join us today. Dr. Van Omeren is the head of mental health unit within the World Health Organization Department of Mental Health and Substance Use. The mental health unit oversees coordinates a range of initiatives, including care for mental disorders across the life course, innovation and research in psychological interventions, suicide prevention, epidemiology, and mental health in specific settings such as the workplace and in humanitarian emergencies. Much of Dr. Van Omeren's work was focused on initiating and developing interagency mental health policies, guides, tools, and interventions specifically for mental health systems in humanitarian settings. Dr. Van Omeren is also recognized for successfully introducing the term mental health and psychosocial support in 2005, which has significantly shaped the field and facilitated multi-sectorial collaborations worldwide. Lastly, we have our own Dr. Kathleen Pike. Dr. Pike is the chair of the Global Mental Health Programs Faculty Steering Committee. Many of you know her from your engagement with the Columbia Council, and we are delighted to have her facilitate a conversation about mental health in the context of emergencies. Dr. Pike is a professor of psychology at Columbia University, where she is director of the Columbia WHO Center for Global Mental Health, deputy director for the Health and Aging Policy Fellows Program, and director of the Mental Health and Work Design Lab. Dr. Pike has pioneered initiatives on the global stage advocating for expanded mental health services and translating research into practice in under-resourced communities, schools, and workplaces. She completed her BA, MA in International Studies and Psychology at Johns Hopkins University and her doctoral degree in Clinical Psychology at Yale University. Please join me in welcoming Matt, Mark, and Kathy for a discussion about mental health in the context of emergencies.
Let's see if we can move this. Mark, can you hear us? All right, good. Are they on? Yeah, they're on. Okay. Hi, Mark.
Hello.
Can you see us or hear? You can hear us clearly. So welcome. Thank you for joining us from Europe. And I'm thrilled to have the opportunity to facilitate this discussion. Just to give people a little bit of orientation, we have about 30 minutes and we will leave time for questions and conversation from all of you. So we have Stephanie Gayet and Raina Marin, who are members of our International Advisory Board, who are joining us online, who'll be watching the chat. So for those of you who are online, if you have questions, please feel free to write in questions on the chat, and we'll try to get to those too. So the discussion today, we thought we'd do some bridging around looking at mental health in the context of emergencies, both in the US and globally, and thinking about emergency from different perspectives, right? So as we think about individuals who are having psychiatric emergencies, what care do they need? And as we think about big macro emergencies, what kinds of mental health issues emerge? And so we're going to start with Matt, with a more local lens. As Deanna said, Matt heads Nami NYC, and Nami has been very significant, a significant voice in the issues around human rights and how do we care for people in emergency settings when they're having an emergency. And part of what's happening in the US in response to that question is the development of 988. So we thought we could start there, Matt, and ask you to share with our friends and colleagues here a bit about why 988, why do we need 988? We have 911. And what is 988 going to be?
So 988 is actually replacing the National Suicide Prevention Hotline. It's a lot shorter than the entire 800 number that would get you there. It's also intended to help to transition some of the role that the police are currently taking on to provide more of a mental health support response than a police or law enforcement based response. For us in Nami NYC, many years ago, we in New York City in 2015, we launched CIT, which is Crisis Intervention Training. It's a national model that's offered in many, many states throughout the country. And our former mayor decided to bring it to New York City. He thought that he could do better than the national model. And so he changed the approach, the way that we implemented CIT in New York City. The model is you ask the police officers to volunteer, and those officers who volunteer get additional training. It's 40 hours of training. And then when a crisis call comes in, those trained police officers go to the scene and they have additional skills to de-escalate a crisis that untrained police officers simply don't have. When you think about the way law enforcement, police officers are trained, they're literally trained. I'm going to ask you to do something. I'm going to tell you to do something. I'm going to make you do something. That's sort of how it evolves over time. That approach is really deeply embedded in who they are. So now to all of a sudden say, now you have to kind of shift this training that you have and show up in a very different way. Well, in New York City, the former mayor decided we're not going to just train the cops that want to volunteer to do this. And when you volunteer, it's because you get it. You want to do it differently. You've seen it. You have experience. You know there's a better way. He said, we're going to train every cop. Well, he never did. We never did get to every cop being trained. But the worst part of that is when police were being deployed, they were not sending cops who had been trained. So we're having we invested so much time and so much money into a treatment approach that just simply was done wrong and incorrectly. And it failed. What we've seen in the last year since 2015, at least, and I emphasize at least 16 individuals in New York City have been shot and killed, and at least 4 more were shot and lived and they were arrested. And all but 2 of those individuals were people of color. So CIT, which is something that we had supported initially and other NAMI affiliates throughout the country continue to support, our stance is not anti-cop. It isn't against a response, but CIT did not work in New York City. So we've now flipped our position on the issue and are supporting a non-police response.
So 988, right? So how many, when people call 911, do we have an estimate of how many of those calls are behavioral health crises, mental health crises?
I don't know what the percentages are, but I can tell you that the city now has a new Be Heard is the acronym for a new response that they're calling a co-response team. So it's a mental health professional and a a mental health professional and an EMS who respond. But the problem with this pilot is that there's still calls coming into 911. So it's the same police dispatch system that's deciding now, do I send the police or do I send Be Heard? They're sending more Be Heards than the police now. And there's some early data that shows that it's working well, but there's still that decision point. And so the police are still often brought into those cases. We're advocating for a non-police response. So there isn't someone with a badge and a gun showing up. But I don't unfortunately have the data on what that looks like. But other models throughout the country, there's a model in Oregon called Cahoots, which has been around for 40 years. And people say here when we talk about non-police response, well, what about when someone's violent? Well, what about, it's a fine line between this mental health emergency and when a cop would really be helpful. What I know from the data from Cahoots for 40 years, it's a single-digit % that they actually end up needing to call the police to assist and support them. So that's a long time and a lot of data. And so we know the model works. There's models in Arizona that are non-police response. So we're just trying to bring the city to step away from CIT as we get closer to the launch of 988. It's coming in July across the country, whether you're ready or not, which is a little scary, but
So 988, for those of you who don't know, as Matt's saying, is scheduled to roll out this summer. It's a very decentralized strategy in the US. Do you know what the strategy is in New York, what the plan is in New York at this point?
So there's an organization called Vibrant Emotional Health, which used to be MHA of NYC. They recently changed their name. They actually are the NYC Well, which is a local support line that you can call. They answer those calls. They also answer a lot of the calls, not all, but a lot of the calls from the National Suicide Prevention Hotline. So now when 988 changes, those calls will continue to be routed to Vibrant. I know that they are looking to hire a lot of people because they need additional staff to support the implementation, but there's a lot unknown in terms of what are the characteristics of when a call does get transferred over, who's deciding, what's the training protocol, and the clock is running out. There's a lot that we don't know. There's actually, we did an op-ed and that was picked up by the Gotham Gazette on all the things that we actually still need to figure out. Who's going out, when, you know, what's going to happen when someone calls, what happens after they show up. You know, we don't really have the diversion centers and the support systems to still continue to divert and avoid the crisis after the Be Heard team does show up. So more unknowns than knowns at this point.
Right. So this is a big issue in the US that our healthcare system is a layered system where there's a national initiative about rolling out 988, but the decisions actually happen at much more local levels. So 988 is going to, although there'll be one number, 988 for the country, depending on where you are, when you call 988, it will go to the system that your region, which will sometimes be a state, sometimes be a city or a district, has set up to receive your 988 calls. So there will be there are, as Matt said, lots and lots of questions and gaps in knowledge. So we'll get back around to what some of those are that you, yeah, please.
We're going to do an event in June called the 411 on 988. It's not scheduled. That's nice, right? We're not, it's not
clever.
scheduled yet, but I have cards over here that I'm going to put out the table before you leave. That's information about the walk, but you can just find us through the website that's there as well.
And we'll be glad, we're glad to send this out to the council. When you have the information, we'll send the 411 on 988 out so people can join. Isn't that clever? I just like saying it, right? It's like, I sound smart all of a sudden, right? Okay, so, you know, when you think of why this happened, right? Why is 988 getting set up? It's foundationally about recognizing the mismatch between the needs of the individual in crisis and the people we're asking to respond. And you know, the police are doing their best and they're doing what they're trained to do, and what they're doing isn't what the certain people need, right? And there's a real mismatch, and that's where 988 has come to the fore. And it's about protecting people's rights and dignity. And I think that those values matter when we talk about an individual in crisis, and matter when we switch gears and think about big macro emergencies. And what do we do? How do we respond when individuals are living their lives and there are macro events like war, natural disaster, displacement? As Deanna said, Mark has led major efforts at the World Health Organization, and as a WHO collaborating center, we have had the pleasure of working with Mark and colleagues on a number of initiatives, and Mark has graciously joined us to talk with us about how the work that he leads at WHO, looking at these big macro events, like right now the war in Ukraine, what are the mental health needs of individuals, and how do you at WHO, Mark, think about the priorities and integration of mental health when you've got a crisis like the war in Ukraine? if you can share with us a bit about the work that you've done and the integration of mental health in that context.
Sure, I'm very happy to do that, and I'm also happy to be here. I admire what you're doing, leaderships of this council, the researchers who are doing important research, and I listened to some of it before, and of course, admire the members of the council for supporting this work. Fantastic. I think one of the questions is, of course, what are the issues in emergencies, and the mental health and psychosocial consequences of emergencies have been very well studied. It's not an area where we lack, where we know very little, know a lot. And psychosocial consequences are very broad and diverse. They range from issues of decreased trust and protection issues in the community, very broad range of psychosocial issues. But I will focus here a little bit more on the issues around psychiatry. And so first of all, actually, most people are quite resilient. That is fortunate because there's so much war out there. Not everybody, but most people are. Many people become very anxious, very sad, very angry during emergencies, usually for very good reasons, because things that are happening are very sad and are very scary, and are very reasons for being angry. But a sizable minority is not resilient. And that's not surprising either, because we all know that adversity, when bad things happen to people, that's a risk factor for mental health problems. So we've really carefully reviewed the literature, and 2 years ago we published in Lancet a review on all of this, and we found that among people who have lived in the last 10 years through conflict, that 22% is likely to have a mental health condition. Of course,
Mark, could you say, sorry to interrupt, could you say that again? I missed what percentage?
22%.
22%.
Yeah.
Got it. Thanks.
Yeah. But that's an average. So there's no place exactly 22%. What's also really important is many people in emergencies, like in any place, will have pre-existing conditions. If there's an emergency tomorrow in New York, there will be people who currently have a mental health condition living through it tomorrow, as of course happened to you 20 years ago. The people with pre-existing conditions are extremely vulnerable in emergencies, and I could talk a little bit about Ukraine if you wish about that. But these people need support, neglect, and protection. And maybe just to mention on Ukraine that currently there's 35,000 people in asylums and institutions in Ukraine who are at extreme risk. So these very old asylums that we wish were converted into community mental health services, but they are still there. They are often at the edges of cities, and there can be fighting around it, and there is it's a terrible issue, and we have a lot of worry and a concern about how to address that. And you can talk a little bit what Bob Baker is doing later if you wish. People who are extremely at risk in emergencies for mental health problems are, of course, the people who go through the most horrific things. There's no doubt. The torture survivors, survivors of sexual violence. These are very potent events, unfortunately. But what is important to remember, particularly among refugee populations, that many refugees escape because horrible things are happening in their country, but they may not themselves have been exposed to the trauma. And because that's what they said, to not be exposed to the trauma. And many of them will not be traumatized. But all of them have an experience of loss. All of them, they lose their community, they lose often family members, they lose their futures, their hope. So sadness, deep sadness, is really a profound part of the refugee experience, which is under-recognized, because usually in the media, among people, we talk about trauma, but loss is really the key experience. not denying that some people are heavily traumatized. And of course, we need help. I can talk a little bit about what WHO is doing, but I'm not sure if you would. I don't want to spend more time on answering questions that you may want me to. But we can talk a little bit.
That's great. Terrific. We'll have some more time. So if I can, a takeaway from what I'm hearing from you, Mark, is many people are resilient, and people, even in the experience of loss and trauma, it's not either or. People can be resilient and have profound loss and be living with trauma. And a significant percentage, depending on the individuals, you said about 22%. One of the things that I wanted to pull out, 22% actually develop mental health conditions that are of significant import. But one of the things that I wanted to pull out that you said, Mark, just by way of comment, big picture, about the 35,000 people living in institutions. These are individuals with mental health conditions who are hospitalized or institutionalized. The push to move people out of institutions around the world, WHO has really led a charge to try to build frameworks that support individuals living in community. And I just wanted to put a spotlight on this, that it's important always, but you've raised one more reason why it's so important to have as many people as possible living in community rather than institutions, because basically right now they're all being left behind in the Ukraine with little option. So if you could elaborate on that.
Sure, I'm glad to. First of all, the 22% is also people who already had, includes people who already had a condition. So the rates double. It's not like from 0 to 22. But on the institutions are just it's just a very dangerous place to live. You've seen it in New York during the COVID-19 worst part of the outbreaks. The people who were in care homes were at highest risk, right, for getting infected and dying. So institutions are just a very dangerous place of living. Now, of course, many people will say in America, when there was decentralization, many people became homeless. So that's also very dangerous, yes. But you get that if you do not invest in community mental health services when you do decentralization. When decentralization is done with investing in community mental health services, you do not get homelessness, and you do not get, as what's happened in the Americas, bigger prison populations.
So actually that's an interesting, another point of intersection, right? As we look at mental health and emergencies, is we're talking about dignity and rights. Yeah. We're also talking about the role of communities. And as we build communities, whether it's communities for 988 or communities that support individuals with serious mental illness so they can live in community, the stronger the fabric of community, the healthier we're going to be, and the more agile we will be as we face emergencies. I want to just, in the interest of time, ask each of you for, this council funds researchers with new ideas, new investigators, to answer questions that make a difference in practice. So what's a question that you would like an answer to?
Well, on the heels of that great conversation with Mark, I think we need to do better about what's happening in the community, because I think even actually a pretty senior person within the Department of Health recently told me we need a map of what's out there. We don't even know what's happening out there. How can we refer people to it? You should map out the community mental health system. I thought, you should map the community mental health system. You're funding most of us. Like, what do you mean? But at the same time, I think we've heard those promises of, well, we're going to deinstitutionalize. We're moving toward that out of dignity and respect, but we're going to invest. We're going to invest. We saw it here with the Allen Hospital closing their inpatient psychiatry unit. There was a big promise of we will invest in community-based services. I said, well, do the investment. And if it works, then close the beds. But you can't close the beds and promise, because we've just been burned by that promise across the country and maybe even the world. But I think that family support is an area that we need to do more research on. I think when we think about mental illness, we very often think about the individual who absolutely deserves services and programs and support of all kinds, but we forget about the family. And I sort of picture that individual standing in the middle of a room, and the family and friends who know them the best and love them the most are that next ring. And then you have the providers in the community and in the healthcare systems, and then the safety net, which we know is unfortunately riddled with holes. So if family and friends aren't educated and supported through these journeys, they can't catch that individual in the middle when they start to fall. And then the system's overburdened. There's waiting lists left and right for access to programs and services. And then they fall through those holes. And sometimes we never find them again, unfortunately. So I think if we were able to show the ROI, so to speak, about family support and the value that it brings and the importance that it has, I feel like we could really make that first rung of that safety net really much more supportive and impactful.
Wonderful. And Mark, how about you from the WHO perspective and a global perspective? Question you would really value answered.
Well, first, before from a maybe less global perspective, but I just on the heels of Matt, is I would love to see the 988 evaluated, because I think that's huge. And congratulations, but of course, there's a lot to be learned on how that goes. So that's I can see 100 studies on that. But on a global level, I also, in line with what Pat was saying, I think there is a real need to study family interventions. In mental health, family interventions are something done by family therapists who have years of training, rather complicated and rather difficult to disseminate globally. Because there's not many countries do not have that many mental health professionals, as we heard earlier from Mozambique. While at the same time, if we talk to people in countries to say, what are your resources? They say it's the family. So individual intervention is fine. Group interventions maybe depends who's in the group, but family is their resource. And we don't have anything out there of scalable psychological family interventions. So I think that's a huge area of work, and I don't think many people are working there in that at all. So it's in line with what Matt was saying, family.
Great, thank you. Yeah, just before you build on that, Raina, I just want to ask you if there are any questions from online.
We do not have any questions yet from
Okay.
the
Great.
people zooming in.
Just didn't want to miss it if there were. So
Sure.
Matt, one last comment there?
Yeah, I think on building on that family piece, we have to take diversity and racial diversity, cultural diversity into account when we're thinking about how to best support families. There's so much stigma within underserved, diverse minority communities, and we know why to some extent in some ways, but we're nowhere near, in my opinion, yet really making headway and inroads into supporting these families that, or in some cases, lots of good reasons not to engage with the healthcare system. But we have to, I think we need to also figure out kind of community by community. The Latinx experience is not the Black experience. It's not the Chinese experience. If we want to affect change in these different ways, I think we have to better understand. And the diverse workforce, I think that we talked about also will contribute to that too.
Well, I want to thank you. Oh, Deanna, please.
We do need a lot of family support, but with the HIPAA laws, I mean, our hands are tied as families. So I don't know, I mean, a person that has mental health issues, for them to manage their own health care is difficult.
So a couple of comments about that. HIPAA is a major issue in the US. It's also an abused restriction that the healthcare system frequently uses to keep people out, keep family members out. So we could have a larger conversation about that. And the other thing is there are strategies to try to help set up permissions and advanced directives. But to your point, this issue of building trust and alliance from the individual to the family to the system is one that's highly problematic in a lot of cases, and appreciate that. Yeah. Now all the questions, and we have 3 seconds left. But yeah, Lori.
I think it's important to support families, but 1, not all families are healthy. 2, a lot of times it's genetics, so they may have as many issues. And 3, sometimes the caretaker burden is such that after years of it, the families want to have their loved ones live somewhere else, or they're getting older and they cannot take it. So I don't think that the whole solution is always family support and community, because I often hear, where can my loved one live? They cannot live with us anymore. We're getting old. We can't handle this anymore. We're not trained. So I think the concept of community living with group homes and trained staff, not punitively, but where people can each live their own life, but with assistance with daily living skills.
Absolutely. Thanks for pulling that out, Lori. I think supporting families includes what you're talking about.
I think they don't
Really.
often know how to navigate those systems, but with the right help and the right care, they can maybe decide where that person will live so that they can still visit and it's close to the home, and they can evaluate the quality of the care and, the questions to ask when they're sort of making those choices and navigating the system. But you're right, and that caregiver burden piece is very, very real.
I know there are a few more questions, but respecting people's times, what I'd like to suggest is we wrap up our conversation, and people who have questions, there'll be time for more informal conversation after we wrap up the whole program. So at the moment, I want to thank Mark for joining us from, I think you're in Geneva at this point, but somewhere in Europe. And thank you so much for joining us and for all the work that you do on behalf of the World Health Organization and the leadership that you bring. And thank you, Matt, for your leadership here in New York. And thank you all for joining us for this conversation.
So I'm Jeffrey Reed. I usually do this thing at the end, just in case things have gone really off track, and so we can sort of pull it back to what we should be talking about, but that hasn't been the case today. So I don't really have that much to add, except I want to say that I'm really excited about the work that the council has supported. I think it's a really important function. These are small projects, it's small amounts of money, but the process is pretty fast. It's vastly faster than the process if you were to go to the National Institute of Mental Health. And so these awards can be made quickly. We have, usually it's the case that we're trying to select the best 4 out of 10 really, really good applications. And so that's a great position to be in, but clearly we could fund more of them if we had more resources. I'm so impressed that it really does work as a laboratory for innovation. I think this geoepidemiology approach is really fascinating. I'm very excited to think about global approaches where you could really look at this. For example, if you're really studying even New York City, the differences, between neighborhoods in terms of the levels of resources and the context that people are in terms of their mental health status would be really important. So I think there are a lot of applications of that. And I think you could think about doing a global mental health survey in a really different way. So I'm very excited because I think that's one of the things about the wave of the future. I think the multimorbidity study is also really important because we need to, with people who have mental health conditions, we need to start realizing that people having more than one thing that's a problem for them is really what most people experience. And our studies have tended to say, well, let's only work on depression and we're going to exclude all the people who have anything else besides depression, or we're only going to talk about the depression and we're going to ignore everything else. So I think these are really functioning as a laboratory for innovative projects that can be done quickly and are being done by, for the most part, young researchers who really represent the future of the field. So it is a dramatically successful program. And thank you very much to Jerry for originating the program, Jerry Miller, and for Jerry and Chuck Goldstein for chairing and leading the process of all the members, and also to Helia and Jeremy and all of the members of the review committee who've been responsible for making such great selections of the project. So it's been a fascinating day. And Stephanie Gayet, who is not in front of me, so I can't remind myself to see it, but yeah, Stephanie has been a key co-chair as well. So it's been a very interesting day. Thank you very much for your attendance, and thank you for your continued support, and tell your friends.